Okay, I see we've got a number of participants on now, so maybe we'll get started here. Hello, everybody. Welcome to today's webinar hosted by the Association of Food and Drug Officials. My name is Jerry Voitala, and I'm the Executive Director of IFPTI. Thanks for joining us today. Today's webinar will highlight some of the IFPTI Fellowship in Food Protection Cohort 9 Fellows as they present their research projects. This is the last of 3 installments of presentations. If you missed the other 2, you can view those other 2 sets of presentations on the AFTA website. These presentations are the culmination of a unique year-long leadership program funded under a cooperative agreement by the FDA Office of Training, Education, and Development and by AFTO. Today, we will experience 4 project presentations. As for the format, the fellows have been given a strict requirement to consolidate the presentation of their project into a 10-minute segment, and we'll follow that up with questions from the audience. If you'd like to ask questions while the fellow is presenting, go ahead and type in your question. Go to the bottom of your Zoom screen and you'll see a Q&A tab, and just click on that and type your question in the Q&A while they're presenting. And then as soon as they finish presenting, we'll get to the questions for each fellow. And just a caution, we may not get to all the questions in the interest of time. So if that happens, feel free to contact the fellow by email or contact IFPTI, and we'll put you in touch with the fellow, and you can learn more about the project that way. So at this point in time, let's get right to it. And we're going to start off with Lacey. Lacey, are you ready for us here?
Yes, I am ready.
Okay, thanks, Lacey.
Would you like me to start sharing my screen?
Yes, please start.
Okay. Good afternoon. My name is Lacey Brown, and I am an IFPTI 2020-2021 Fellow from Port Arthur, Texas. Thank you for attending my presentation. Today, I will be presenting my research titled City of Port Arthur, Texas Inspection Practices. Did they have an impact upon critical food safety violations between 2017 and 2019? Let's talk about the background for this study. In May of 2015, the City of Port Arthur signed up for the Retail Program Standards. Now, let me tell you a little about the Retail Program Standards. The purpose of the Retail Program Standards is to serve as a guide to regulatory retail food program managers in the design and management of a retail food regulatory program. The Retail Program Standards are designed to help food regulatory programs enhance the services they provide to the public. Now, in April of 2016, food safety staff here at the City of Port Arthur attended a standards workshop, and we began implementing the standards in mid-2016. Now, let's review some of the inspection practices that were modified as a result to implementing the standards. As a result to implementing the standards, the City of Port Arthur implemented uniform inspection practices, developed a department policy that required routine inspections and follow-ups to be scheduled on a consistent basis. We also modified the staff development and training program to better prepare the food safety staff for our program. We were also able to acquire additional food safety personnel. The next chart will put these changes into perspective. This is a look at before and after the adoption of the Retail Program Standards. And this takes us into our problem statement. Our problem statement is how newly adopted City of Port Arthur inspection practices impacted critical violations at restaurants between 2017 and 2019 is not known. Now let's take a look at the research questions that help me assess the problem statement. Research question 1 is, what is the rate of critical violation for restaurants in Port Arthur, Texas from 2017 to 2019? The second question is, how have the retail food inspection practices changed in the city of Port Arthur from 2017 to 2019? And lastly, how do restaurant operators believe adoption of the retail program standards by the Port Arthur Health Department has impacted critical violation rates from 2017 to 2019? Which takes us into the methodology for this research. The research was conducted in phases. In the first phase, I obtained inspection reports for food service establishments from 2017 to 2019. In phases 2 and 3, I developed a database with inspection report data, identified changes in inspection report data, and other data trends. And in phase 4, I conducted interviews with the restaurant person in charge to discuss the City of Port Arthur inspection practices and their perceived impact of inspections. Let's discuss the study population for the research. My study population is all restaurants in Port Arthur, Texas. And this brings us to the results of the research. This chart shows the average critical violations received during inspections. As we could see, from 2017 to 2019, the average number of critical violations cited per inspection fell from 3 violations down to 1 violation. Continuing with results, let's take a look at this chart, which shows the rate of critical violation per restaurant. Let's focus on the orange line in this chart. We see that in 2017, there was a critical violation rate of 76%. There was a slight reduction in critical violation in 2018 when it dropped to 68%. But as we see in 2019, the rate of critical violation decreased to 52%. Now, continuing with the results, we will look at changes in food safety program policies in the City of Port Arthur. This chart illustrates the City of Port Arthur policy changes. The orange bar represents 2016 and displays data before implementation. And the yellow, green, and blue bars represent 2017 through 2019 respectively and display data after implementation. The data shows that the number of total initial inspections increased and the number of follow-up inspections also increased after implementation. The number of violations that were corrected on site also increased after implementation, while the number of repeat violations decreased after implementation. Let's discuss the interview results. A criteria was established to select the restaurants for participation in the study, which included restaurants that had at least 20% increase in inspection scores and at least 50% reduction in critical violation rates between 2017 and 2019. After invitations were sent out, we ended up with 40 total interviews, 32 were via telephone, and 8 were in person. Here are the results of those interviews. 95% of those interviewed stated that they believe the feedback from the City of Port Arthur health inspectors helped correcting violations. Almost 80% stated that the City of Port Arthur health inspector pointed out violations during that inspection that they were not aware of prior to the inspection, while 15% of those interviewed stated that they believed internal company policy changes assisted with the reduction in critical violations noted during their inspections. And that brings us to the conclusion. To conclude, I found that there was an increase in critical violation, which correlated with an increase in inspections overall. However, there was a decrease in violation rate, overall from 2017 to 2019. The Food Safety Regulatory Foundation was put in place, which paved the way for improved inspection procedures and protocols. As for the interviews with the restaurant person in charge, it is unclear if my presence as interviewer influenced the response of the interviewees. And here are my recommendations. The City of Port Arthur should continue to monitor compliance with implemented inspection policies to assure continued emphasis on addressing critical violations through on-site corrective actions, re-inspections, and follow-up inspections. And I would also like to acknowledge those that helped me through this research process. I would like to thank the entire IFPTI staff for selecting me for this opportunity and helping me through the entire process. I would like to thank Kathy Fetter, my mentor. She was always there for me when I needed her. I don't think that I would have been able to make it through this process without Kathy. She has been a lifesaver. I would like to thank my fiance, Lou, who has been supportive and helpful in every way possible throughout my research process. My daughters, Madison and JC, have been amazingly supportive and patient as well. I am eternally grateful to be an inspiration to them. To my family and friends, thank you for understanding when I could not participate in every activity or function. And last, but certainly not least, to my supervisor, Judith Smith, for allowing me to participate in the IFPTI Fellowship. You have been a true role model that exemplifies leadership. That concludes my presentation. I am open to take any questions at this point.
Okay, thank you, Lacey. So go ahead and type your questions in the Q&A box. Click on that Q&A at the bottom of your screen and feel free to type in some questions. And I see we have some coming in, Lacey.
Okay.
So here's one question. What is included in your newly implemented department policies?
Our new policies included written procedures on inspection practices, how to perform inspections, when to perform inspections, the routine, the follow-ups, compliance protocol, enforcement protocol, as well as staff training and development.
Okay. Okay, another question coming in. Why do you think the number of inspections increased, and why didn't the new staff training slow down the ability to increase your numbers of inspections?
Well, I believe the number of inspections increased as a result of the new protocol put in place. The new protocol put in place a consistent schedule of routine as well as follow-ups. It is my understanding of the research that prior to implementation, routines were not done consistently, nor were follow-ups done consistently. So once a foundation was put in place, we were able to inspect at a rate that is needed to ensure food safety.
Great. Okay. And here's another question. What are uniform inspection reports?
Uniform inspection reports are not only the forms, but they're procedures established to ensure uniformity with all staff here, as well as we use a state form. So it's uniformity and consistence with compliance, enforcement, and inspection practices.
Okay. And another question here. Were the addition of personnel to your department the result of the adoption of the retail program standards?
Yes, I do believe it was directly a result because one of the standards, Standard 8, helps with resources that you need to support your program. And so that standard was utilized in requesting additional staff.
Great. Okay. And there was already a question about training. So here's another one. What does your staff development and training include?
The staff development and training includes videos provided by the FDA. So there are videos on laws, there are videos on bacteria loads and the foundation for any food safety inspector to learn prior to entering the field. Once they complete those videos, the new staff begin the in the field training where they shadow a trainer. So it's a trainer-led inspections. And then once they complete shadowing, the new inspector actually leads the inspection while the trainer assess them. And once that's complete, we evaluate the training and assess for readiness to enter the field.
Great. And then here's a question from someone. Any hunches which policy might have the most impact on reducing the violation rate?
I would say it is the follow-ups. I believe that when you cite someone a violation on the inspection report, it's critical to follow up on that. It sets a precedent with the establishments that this is important, and we will continue to work together until we get it correct. So I think follow-ups are very, very important to help with compliance.
Okay, great. And I think our questions are slowing down here. So I'm just going to stop and congratulate you, Lacey. Great project. Thank you very much for sharing that with us today.
Thank you.
Okay, and if you can give up control of your screen, we'll go to our next presenter, and that will be Amanda. Amanda, do you want to take control?
Yes, hello. Thank you everyone for joining us on this fine Friday afternoon. We very much appreciate it. I'm Amanda Garvin. I'm a regional food safety specialist with the Michigan Department of Agriculture and Rural Development. I have a Master of Public Health and Bachelor of Science in Medical Laboratory Science. 8 years of my experience are in food safety, along with 8 years of experience in laboratory and an additional bonus year of epidemiology experience. Today, it's my pleasure to present to you my research project on the use of copper as a food contact surface for alcoholic beverages within retail food establishments. Something you need to know before we get started. The 2017 FDA model food code is a model guidance that FDA issues. They issue it every 4 years with amendments every 2. And this is a guidance that local and state regulators can adopt, and many have. Within that guidance, it states that copper cannot be in contact with food which have a pH below of 6.0. There are a few exceptions to that, but those exceptions don't relate to today's topic. Also of interest might be a Conference for Food Protection issue in 2018 that also deals with this topic. And the topic number or the issue number is right there for you if you have any interest. A common mule cocktail is a Moscow Mule, and that mule cocktail is often put in a copper mug. And as you can see by the pHs on the screen, it has a pH well below 6.0. So it, according to the 2017 FDA Model Food Code, could be a food safety issue. So if it is a food safety issue, why do retail establishments want to use it? It is an extremely desirable surface. Copper is believed to change the flavor of the beverage as you drink it. And frankly, it looks really unique. I'd be remiss though if I don't mention copper is essential for life, but just as anything else, too much copper is harmful. Also, something to keep in mind as we go down the yellow brick road of food in contact with copper. Copper release increases with lower pH, aka high acidity, higher temperatures, and more contact time. So the two surfaces that my research really focuses on are copper in distillation and with mule cocktails as the mug. I started originally researching copper mugs specifically, but as I was researching that, I actually found copper being used in craft distilleries. So copper mugs, there's limited research, and I already kind of covered what we do know about them. But distilleries, there's actually a long history of using copper in actually distilling the liquor. It's been used all the way back to the 15th century. And here's 4 common liquors that are distilled in copper. There are others. And as you can see on the slide, it also mentions within the studies that were found what copper levels were found in some of these liquors. An important factor to realize is to distill a liquor, it must be heated up to 158 degrees Fahrenheit and 173 degrees Fahrenheit for periods over 12 hours, which as previously mentioned, heat can cause copper release. This elicits the question, what is a safe copper level? And a common way that we can usually compare this is copper and water, because we've done research on this. Within the United States, the EPA drinking water level is a 1.3 milligrams per liter goal, and the World Health Organization and Canada have a 2.0 milligram per liter. Most of this is based on 3 childhood diseases along with an adult disease. The childhood diseases, I'm kind of disregarding in this respect, just because we're talking about drinking, which is in adults. So Wilson's disease is the adult disease that we still need to take into consideration. There's about an estimated 9,000 cases in the United States. Also, there was some other studies that were done. One of those studies did find 3 milligram per liter of copper intake. Did it cause a 12% increase in mild non-life-threatening gastrointestinal illness? And with that, I'm going to talk about some of the historic outbreaks with copper, which mostly copper is related to carbonators. So whether that's a soft drinks actually being produced and bottled, or at the point of sale. Also, copper has been found in drinking water, and when you're talking about storing liquids for a long period of time. After looking at what I discovered in the research, I formulated my problem statement. The risk of using copper as a surface in contact with alcoholic beverages by industry and retail food establishments is unknown. From this statement, I drew the following research questions. How commonly is copper used in contact with alcoholic beverages by industry? How do local, tribal, and state regulations differ from the 2017 FDA Food Code regarding allowing the use of copper in contact with alcoholic beverages? And how many foodborne illness outbreaks are associated with the use of copper as a food contact surface are known to have occurred? How I went about that research was threefold. 2 were surveys I sent out. The first one was sent out to state, local, and tribal regulators over retail food establishments. And that included a directory of state and local officials through AFDO, the directory of CFP members, and a list of FDA inspection training officers. The second was an anonymous survey that went out to retail and craft distillers through the National Restaurant Association. And the third one was seeing what current illnesses or outbreaks were out there through the American Association Poison Control Center through their National Poison Data System. So let's start by reviewing the regulatory survey. I sent out 573 surveys and received back 88 responses. This covered a total of 36 different states. 53 of those were state regulators and 29 were local. But of the 88 responses, only 83 regulated retail. So the rest of the questions focused just on those 83. 80 of the 83 responses were at least loosely related on some form of the FDA model food code. 6 respondents stated that their law specifically does allow the use of copper in contact with alcoholic beverages, and 5 others actually said their regulations were completely silent about copper. So to delve a little bit deeper on that, this graph shows the 93% of respondents that stated they follow the recommendations of the 2017 FDA model food code regarding copper, specifically in contact with acidic alcoholic beverages. Of those respondents, 36% do allow copper in retail establishments for service only. With the other category, that includes people that were not sure, they said it depended on the pH of the drink, And there was also a few jurisdictions that allowed variances to the regulation, specifically in regards to copper mugs. Also of note is 11 other jurisdictions that commented that they would allow a variance if the retail establishment submitted a request with sound science to back up their request. Now let's discuss craft distilleries. 52% of respondents inspect craft distilleries under retail regulations. Of those 52%, 58% of those do allow copper as part of the distillation process. So when I'm saying 52% regulate under retail, these are not CFRs. It is under an equivalent to a food code. And then 23% of them weren't sure. They'd never really asked. And there was specifically one respondent that did say they do not allow copper in craft distilleries. Let's talk about the industry results. So unfortunately, we had this wonderful thing called a pandemic that occurred. So the National Restaurant Association and I agreed that this was probably not the best time to send out a survey to them. And my research ended before the pandemic did, since it's still ongoing. So we're going to hold it off until the pandemic ended, but that's not going to happen. The last part of the research included collecting information from the AAPCC. I did receive an email back from them saying since there wasn't a lot of information in their system, they weren't going to pull it for me, but I did find on their website annual reports, and within those annual reports, it actually did list out copper. And as you can see from this chart, from 2012 to 2019, there was no more than 700 reported cases of copper exposures per year. Exposures meaning they were exposed to it, but not necessarily got ill from it. And then as you can also see from this chart, only a portion of those are even adults. So that would include it under legal drinking age. This concludes the data that I collected. Several conclusions can be determined, which represent the key findings of my research. Over 1/3 of regulators surveyed allow the use of copper mugs, and over half allowed copper as a food contact surface in distilleries for alcoholic beverages. Even though there is a high consistency of regulatory adoption regarding copper being prohibited as a food contact surface, many within this survey are not enforcing their existing regulations, which would not allow the use of copper in contact with alcoholic beverages due to the high acidity level of alcoholic beverages, because as previously stated, 93% of the respondents stated they follow the 2017 FDA model food code regarding copper as a food contact surface. And then lastly, in regards to outbreaks, the outbreak results discovered within the research showed that copper is a very low cause of illness in general, but it's unclear why. Is this specifically because foodborne illness or ingestion of copper has minimal risk? There's a lack of data that we're currently collecting due to copper ingestion, or the use of the restrictions are actually working and we should change nothing. Based on the data collected and the conclusions formulated, the following are my recommendations. Number one, toxicity from copper in contact with alcoholic beverages appears to be a candidate for thorough risk assessment. A risk assessment would be super important to be able to provide to industry regulators and consumers. That way they have a science-based information to back up their decisions on the safety of copper as a food contact surface for the purposes specifically outlined today. Number two, with the increased popularity of meal cocktails, studies should be conducted to determine if there is a safe level of copper in alcoholic beverage. A maximum safe time in alcoholic beverage can be in contact with copper. This information would be helpful for regulatory agencies to either change their existing regulations, change their existing practices, or maybe even create variances that are safe. And number three, more research is needed to be conducted on the low incidence of copper poisonings, because we really need to know what is really behind that low incidence. Finally, I'd like to acknowledge a few people that have helped me out a lot in this project. My supervisor, Sean Dunleavy, the entire local health services team, they got to listen to me go over this project for the last year, so I really appreciate their time. my mentor, Doug Sanders, the entire IFPTI team, all of my Cohort 9 fellows, which someday I'm really hoping to get to meet. The survey respondents, thank you very much for your time. And I had a lot of past IFPTI fellows who reached out to me, and I really appreciate that. Thank you. So is there any questions?
Okay. Thank you, Amanda. Now's the time for questions. And I see some people have already started typing in their questions. That's good. So go to the bottom of your screen, type in the Q&A box. And I know some people are using the chat, so I'm watching that too, so that's okay. But go ahead and type your questions in. And we've got a question already. So Amanda, is there any requirement for bars or distilleries to have a consumer advisory on the possible health effects of copper?
No, there's not right now. There's it might not be a bad idea to research into, but again, there's just not a lot of research at all on this. So it'd be hard to have it. What would you be advising them of? Because we don't know if it's a risk or not at the moment.
And I think we'd have to look at susceptible populations that would be going to a bar, I'm guessing. Okay, good. And here's another question. What happens if someone who doesn't have Wilson's disease has too much copper intake?
So luckily copper, it doesn't actually affect too much. Like there's no reproductive issues. There's no cancer associated with it. In somebody who is susceptible, it could cause some renal failure, but that's because they're already in renal failure. But other than that, it's really the vomiting, the diarrhea, and in almost immediate emetic effects, but it doesn't build up in the system.
Okay. And here's a comment from somebody. I think it's pertinent, even though the commenter says this isn't a question, just an observation. A few years ago, I reached out to a copper mug manufacturer, and they were completely unaware of the food code prohibition. They thought I was asking about the purity of copper in the mugs. So that's an interesting take.
And actually, that's actually really common, in something that in talking to some of these people I found was the people who sell the vodka and different alcoholic mixers actually will give out free copper mugs. So a lot of these bars were getting them from free.
Wow. Okay, and we have another question for you. Why do you think regulators don't enforce the food code requirements uniformly on copper and alcohol?
In my own humble opinion, because I don't think people realize or even know whether this is a risk. It's something commonly done out there. They see it everywhere. And it's hard to believe if it's done all the time and we're not seeing illnesses, that it can be a risk, but it still might be a risk. We just don't know yet. So I can totally see why people are not regulating it.
And I think your project points out that a risk assessment is surely needed. Okay, and we have another question. Why wouldn't this be regulated by liquor control?
So I actually talked to Michigan's liquor control, and she stated that this is not something they look at all. They don't look at a level of something within the food. They would look at the process, but copper is definitely not already on their radar at all. So this is something kind of as a food safety thing, not so much a making sure someone doesn't overdose on liquor.
Got it. Okay, and let's see, oh, here's one. Oh, a couple more questions, I guess. Are you aware that copper is also sold in food stores as cookware because it's supposed to conduct heat very well?
Yeah, actually that is, there was one state that talked about, I don't have my notes right here, but oh, here we go. Virginia actually allows the use of copper and copper alloys to do their apple butter and molasses. So apple butter and molasses is another one that has a pH below 6.0, and it's very common to do those in copper also. So that is another thing that we do all the time in copper, but we don't have a lot of research on that I could find. But yeah, that's something that the food code does still prohibit. It doesn't matter if it, as long as it has an acidic pH, it doesn't matter what the food is, whether it's a liquid or a actual food item, you're not supposed to be cooking that in copper. So it really does negate the question, is it an issue if all these people do happen to have copper in their house and we're not seeing illnesses?
Okay, and let's see, and here's another comment from someone. Liquor control does not typically focus on food safety, from one of our viewers. And let's see, here's another question. Do you think there is hesitancy to make complaints, since a complicating factor in illness symptoms is the alcohol consumption itself?
Yeah, that is actually part of the question with somebody who does overdose in copper. Is it because it's due to the copper, or is it due to having too much to drink? But there's also, so my data collection that I was looking at for copper, it's all forms of copper. So it's not even due just to ingestion. So that is copper in total, and the exposures of it every single year. There's only under 700 exposures, no matter what the route is. So it would be intriguing to know if it is because they've had too much to drink, or if it's from overdose of copper.
Well, another great presentation. Thank you, Amanda. I'm not seeing any other questions coming in, so great job. If you could give up control, we'll go to our next presenter.
Good afternoon, and thank you for your continued attention this afternoon. My name is LaShantala Kendall, and I hail from Kingston, Georgia, by way of Monroe, Louisiana. I'm currently a registered sanitarian and work with the Environmental Health Department in Camden County, Georgia. Today, I am pleased to present my research project entitled, Are Your Hands Clean? A comparison of foodborne illness reporting in states that have different bare hand contact requirements. Before I was employed by Camden County, I worked for another state's health department, and their regulations allow for bare hand contact with ready-to-eat foods. Now, Georgia does not allow for bare hand contact with ready-to-eat foods, but will allow for exceptions with appropriate documentation and prior approval from the state regulatory authority. Because of the different bare hand contact requirements within different states, I wanted to dig deeper to see if more stringent bare hand contact rules might impact rates at which foodborne illness outbreaks are reported. As background, foodborne illness is a preventable public health challenge that causes an estimated 48 million illnesses and 3,000 deaths each year within the United States, according to the CDC. The CDC has also stated that one of the biggest causes of foodborne illness outbreaks is improperly washed hands. The National Advisory Committee on Microbiological Criteria for Foods concluded that minimizing bare hand contact with ready-to-eat foods provides an additional means of interrupting disease transmission. One research study has even stated that bare hand contact with ready-to-eat foods is responsible for 30% of restaurant foodborne illness outbreaks. Ready-to-eat foods are those foods which are edible without an additional preparation to achieve food safety. Within food safety establishments, there are certainly numerous factors that can contribute to foodborne illness. However, the most common component within all foodborne, However, the most common component within all food service establishments is food service workers, all of whom which have some form of contact with the food before it reaches the consumer. The 2005 FDA Food Code was the first version to recommend minimizing bare hand contact with ready-to-eat foods. Since then, many state and local food safety regulatory agencies have adopted those requirements. However, there are still state and local agencies that allow bare hand contact with ready-to-eat foods or allow for variances to the no bare hand contact requirement. No bare hand contact, usually demonstrated by the use of gloves, is quite often interpreted by consumers as meaning the food is safe. However, no bare hand contact with ready-to-eat foods is not a fix-all. And as an inspector who has now worked in 2 different states, I'm seeing many avoidable mistakes by food service workers, and I'm sure many of us have as well. All of this leads to my problem statement. How foodborne illness rates in states that allow bare hand contact with ready-to-eat foods compare with foodborne illness rates in states that do not allow bare hand contact with ready-to-eat foods is unknown. The research questions developed to address this problem were, number 1, which states allow bare hand contact with ready-to-eat foods? Number 2, among selected states, grouped according to their bare hand contact requirement, what are the rates of foodborne illness that occurred between January 2015 and December 2018? And finally, number 3, what differences exist in rates of foodborne illness outbreaks based on type of retail establishment and bare hand contact requirements? The methodology used to address these questions included the following. First, states were identified based on their bare hand contact with ready-to-eat food requirements in place during 2015 through 2018. Now, those states were then grouped according to their bare hand contact requirement with ready-to-eat foods, and then 3 states were randomly selected from each group of states. So Group A, which were the states that allow bare hand contact with ready-to-eat foods, and in this group was California, New York, and Texas. Group B were the states that prohibit bare hand contact with ready-to-eat foods, but allow for variances with regulatory authority approval. And those states were Florida, Georgia, and Louisiana. And then Group C were the states that strictly prohibited bare hand contact with ready-to-eat foods. And those states were Tennessee, Maryland, and New Mexico. Second, foodborne illness outbreak data was obtained from the CDC National Outbreak Reporting System, or NORS dashboard. Now, for the 3 states within each group for the 4-year period of January 2015 through December 2018, and included only outbreaks associated with the top 8 pathogens that could be spread through bare hand contact with ready-to-eat foods. And in order to evaluate each state's foodborne illness outbreak data from an equivalent standpoint, overall foodborne illness outbreak numbers were converted into numbers of outbreaks per 1 million population for each state. And last but not least, to determine the primary locations for each outbreak within each state, NORS data for the top 8 pathogens and based on the type of establishment was utilized and converted into number of outbreaks per 1 million populations. Evaluation of data led to the following results. This chart shows the total number of reported outbreaks within each group of states for the top 8 pathogens that could be spread by bare hand contact. Now, although there are variations within each group, generally the highest numbers of outbreaks were in Group A. Those are the states that allow bare hand contact with ready-to-eat foods. The second highest numbers were in states that prohibit bare hand contact with ready-to-eat foods, but allow for within exceptions. And the lowest numbers were in states that strictly prohibited bare hand contact with ready-to-eat foods. Now, this second chart shows rates of reported foodborne illness outbreaks per 1 million population, and these are based on the top 8 pathogens that can be spread by bare hand contact with ready-to-eat foods. Generally, this chart shows the opposite of the previous chart, with the higher rates of outbreaks within states that strictly prohibit bare hand contact with ready-to-eat foods. So Table 3 shows rates of reported foodborne illness outbreaks per 1 million population, and these are based on single state outbreaks and the type of establishment. Generally, the rates are highest within sit-down restaurants in all three groups, while those states with the lowest rates in sit-down restaurants are in Group A, and those are the states, again, that allow bare hand contact with ready-to-eat foods. And then Group B were the states which prohibit bare hand contact with ready-to-eat foods, but allow for exceptions. The following conclusions are reached. Now, while a majority of state and local food safety regulatory authorities operate under some version of the FDA food code, there are variations in the no bare hand contact with ready-to-eat food requirements. While raw total foodborne illness outbreak numbers were generally higher within states that allow bare hand contact with ready-to-eat foods, data showing foodborne illness outbreak rates per 1 million population generally showed the opposite, lower rates of foodborne illness outbreaks within states that allow bare hand contact with ready-to-eat foods. Now, restaurants in particular, sit-down facilities show significantly higher rates of foodborne illness outbreaks than other types of retail establishments within all three groups. However, the generally lower rates were in those states that allow for bare hand contact. This research leads to the following recommendations. A more comprehensive study, which would include more states, should be performed to determine how closely foodborne illness outbreaks are related to bare hand contact with ready-to-eat foods. Additionally, the comprehensive study should also investigate the impact that other foodborne illness risk factors have upon foodborne illness rates. Further study of sit-down restaurants should be conducted to determine more accurately if sit-down restaurants are more or less likely to be implicated in foodborne illness outbreaks. And lastly, strict food worker training regarding bare hand contact risk, proper hand washing, and other risk factors associated with foodborne illness outbreaks should continue to be provided by both regulatory agencies and the food industry. I would like to acknowledge some special people, Doug Saunders and Kathy Fetter, my IFPTI mentors, to whom I am forever grateful because they refused to allow me to give up on myself. A very special thank you to the Department of Public Health, Coastal Health District 9-1 for their encouragement this past year with my participation in the IFPTI Training Institute Cohort. A special thank you to both Coastal Health District Director Dr. Lawton Davis and District Environmentalist Brent Phelps for their exemplary support along this journey. Additionally, a very special thank you to my supervisor, Terry Farrell Jr., for his guidance and support throughout my participation in this fellowship. And finally, I would like to thank my other fellows for their unyielding and professional encouragement throughout this year. I've gained 10 new friends and colleagues from this experience, and I will forever be grateful. And I am ready for questions.
Hey, thank you very much, Shay. And go ahead and type your questions in the Q&A box, and we are already starting to get some questions. Shay, here's a question. What was the rationale for bare hand contact in states that allowed it? Why don't they require gloves or utensils for food handling to reduce bare hand contact?
I think during the 2015 era time period that I was looking in, many states just had not adopted a stricter bare hand contact with ready-to-eat foods. Maybe more research needed to be done during that particular time. But it's not a requirement for the states to adopt the FDA food code. It's only a recommendation. So it just has to trickle down to that state agencies.
Great. And another question, what are the top 8 pathogens you talked about in your research paper?
I looked at Salmonella, Clostridium perfringens, Campylobacter, Listeria, hepatitis A, E. coli, and Vibrio.
Sounds good. All right, we have some other questions trickling in for you. How did you choose which states to research?
It's really funny. It was kind of random. I put each state that I grouped into A, B, and C into a fishbowl, and I had my daughter to pull them out at random. So it was truly random.
Okay, that's a good way to do it. Okay, another question for you. Why do you think the states with more restrictive bare hand contact rules yielded higher rates than the less restrictive states?
Well, in those states where the gloves are used, education on how to use them correctly is probably needed. I've seen countless times where food service workers will be in the food prep area prepping food, and then they'll stop and take some trash out and then come back, try to return back to the food prep area without one, changing their gloves or washing their hands. So just more education is probably needed because gloves do give us a false sense of security. So just more education will be probably needed in those particular states.
Okay. And another question. You think there are some confounding factors that impacted your results, like the differences in how some states report foodborne illness?
Absolutely. Because I use the CDC NORS dashboard and the states are self-reporting, some of the numbers could be more or greater, just depends on if during that time frame, all of the foodborne illness outbreaks were reported from their particular state.
Right. And Shay, I think I'm not seeing other questions pop up. So I think you're all set. Well, thank you. Great presentation, great project. Thank you for that, Shay. And that brings us to our next presenter. So Emily, would you like to take control? And if you take yourself off, there you go.
All right, is that, did everybody see that?
Looks good.
Okay, all right, well, let's see here. Hello, and thank you for being here. My name is Emily Herbst with the City of St. Cloud, the Health and Inspections Department as an Assistant Health Director. Today, I'll be discussing my project, highlighting the strategies to improve food safety communication between the St. Cloud Environmental Health Program and East African food operators. We'll begin by discussing some background information about St. Cloud and the Health and Inspections Department. St. Cloud is one of the larger cities outside of Minneapolis and St. Paul, centrally located in the state. The Health and Inspections Department has 2 inspectors conducting all food, pool, and lodging inspections. Our program holds a delegation agreement with both state health and ag departments. Our inspectors conduct routine inspections to a diverse food community with various risk levels and inspection challenges at nearly 500 retail food establishments. In 2019, a risk assessment was conducted to evaluate compliance trends. This risk assessment was broken down by priority designations, priorities 1, 2, and 3. The Minnesota Food Code priority designation explains the severity of the public health significance and inherent risk as applied to the sections of the Food Code. On this slide, I've listed brief summaries of each designation as noted in the Minnesota Food Code. These designations are considered the same as FDA's priority designation, priority foundation, and core designation. In order to narrow down our assessment focal point, we prioritize the top 20 establishments with the most priority 1 and priority 2 items. We noticed numerous trends, but the first starting with the food service types in the group. 60% of the establishments were ethnic-based retail food establishments, and 8 of the total establishments were East African. In addition to this data, we noticed a high non-compliance rate among 2 violations, the person in charge and the certified food protection manager. The CFPM is a certified person who acts as a subject matter expert for the specific retail food establishment in which they work. And then the person in charge is the designated employee who ensures compliance with the Minnesota Food Code. So listed on this slide is a summary of each section in the Minnesota Food Code. It should be noted that the CFPM does require state approval for the certification, and there is a specific renewal period. For this renewal period, additional education credits need to be earned or the exam needs to be retaken. In conjunction with this assessment, the Health and Inspections Group applied for a grant in late 2019 to provide free and local translated learning opportunities for our East African retail food operators. In early 2020, the department received a small projects grant from AFTO, allowing us the additional funds to hire a translator to execute the training. A local professor from St. Mary's University was hired out to present the CFPM course and provide translated training material, a translated presentation, and translation assistance on the final exam. Our department also worked with a local nonprofit called the Initiative Foundation to help with the collaboration efforts. In order to better understand the effectiveness of the CFPM training and pinpoint the cause of noncompliance with the person in charge and the certified food manager violations, we determined that the effectiveness of the City of St. Cloud Health and Inspections food safety education and education and communication strategies currently employed at East African food establishments is just unknown. Now we'll discuss some of the research questions that help guide this project. The first being, what barriers do St. Cloud East African food establishment operators believe exist relative to fully meeting food safety education requirements? Next, how are the current requirements of the certified food protection manager and the person in charge being implemented to increase food safety knowledge for St. Cloud East African food establishment operators? And then finally, what strategies can the City of St. Cloud employ to assist St. Cloud East African operators in meeting food safety education requirements? To summarize the project, I'll describe some of the research methods. We hosted a completely translated CFPM training. The trainer also provided translated assistance on the exam. A questionnaire was provided after the training and prior to the CFPM test addressing who was in attendance, previous work experience, and the expectation of available training opportunities. One-on-one interviews were conducted after the training with those that attended to compile additional feedback, such as feedback from the training opportunity, other training opportunities that they would like to see available, and finally, feedback on communication barriers experienced as a food employee. These interviews were conducted along with the translator to ensure the answers were documented appropriately and a level of comfort was maintained. Data was tracked and recorded, as well as exam results were provided from the trainer. To better understand those participating in the methods listed previously, our study population consisted of those St. Cloud East African food establishment operators. So now let's discuss the results. 6 out of 7 who attended were retail food operators from St. Cloud. So for the purposes of these slides, I will only be referring to the 6 attendees from St. Cloud. 6 completed the pre-course questionnaires. 3 completed the post-training interviews. All 3 of the interviewees explained that they viewed language as a primary barrier. There were common misinterpretations, such as a misunderstanding of city staff explaining violations found while conducting those inspections. The written inspection reports, handouts, and the Minnesota Food Code in general were all common misinterpretations that the interviewees provided. 2 out of 3 misunderstood the CFPM renewal requirements. The same interviewee suggested offering translated educational credits that will help them maintain their CFPM. Then the retail food operators explained in both the interview and the questionnaires that they were both the CFPM and the person in charge. On the questionnaire, 5 out of 6 explained this was their first food safety training. Interviewees also explained that they had trouble attending the 2-day training, as most of those attendees noted that they're the only employee on site. Interviewees requested annual translated CFPM trainings. Operators who attended the training explained they understood the content, and this was reflected through the passing scores, exam scores for all the attendees. And then finally, through the interviews, most of the data collected were anecdotal from experiences and suggestions just from the business owners as business owners. The previous slides just highlight some of the information received from this project, but we were able to make some conclusions based off this information. The First, being a primary barrier between the city of St. Cloud and the East African food establishment community is misunderstanding basic food safety principles identified during those routine food inspections due to a language barrier. The lack of translated educational materials and resources provided by the city of St. Cloud has been identified by the East African food establishment community as a missing connection to ensuring the person in charge in CFPM have the resources necessary to meet the Minnesota Food Code requirements. As most East African food establishment operators are the CFPM, the person in charge, and the only employee of the food establishment, the availability of translated materials, translation services, and translated educational opportunities available in alternative formats provides increased opportunity for compliance efforts. And then finally, the City of St. Cloud, the Health and Inspections Department, has utilized available grant funding and partnerships to address language barriers. Based on the success of previous efforts, the City of St. Cloud should seek community support and funding and host events that build community relationships to aid in eliminating communication barriers. So from these conclusions, we recommended that the St. Cloud should offer translated materials online and as handouts. St. Cloud should continue to offer discounted CFPM opportunities and educational credit opportunities. Then finally, city staff should apply alternative methods of ensuring compliance with the CFPM and the person in charge requirements. This project could not be completed without mentioning and giving recognition to some of the following people. Thanks AFDO for considering our department for a small project grant. Thank you to the Initiative Foundation for collaboration efforts and continued partnership. And thank you greatly to FRIA for your expertise and willingness to provide this training. Thank you to the Rivers Edge Convention Center for hosting and training while maintaining all of our COVID-19 executive order requirements. And then a huge thank you to the St. Cloud community for not only participating, but providing honest feedback. And finally, thank you to St. Cloud staff and IFPTI fellow mentees, mentors, and staff, because their constant support, feedback, and encouragement were everything. So I would like to take this opportunity to ask if anyone has any questions.
All right, thank you, Emily.
Yeah.
And go ahead and type your questions in the box at the bottom of your screen. And we are already getting questions coming in for you, Emily. So
Okay.
let's start with the first one. Besides the certified food managers and/or PICs, are the food workers themselves at these restaurants required to obtain and show proof of basic food worker training?
So in absence of a person in charge or CFPM, the employee should demonstrate knowledge to an extent.
Okay. All right, and other questions coming in. How did you choose just 20 establishments instead of more from the risk assessment?
We basically chose that at random, just due to staffing sizes and for time consumption and efficiency. We just decided to do 20. I think it would benefit our department and other agencies if we did more. But just because of that, we decided to do 20.
Okay. Another question. How did you establish what an ethnic establishment was?
So we did it based off of two major qualities. So the types of food that they were serving, and then whether English as a primary language was not spoken at that establishment. So.
So that was, it sounds like from inspector experience from going in there. Okay.
Yep.
Okay. And another question. Have you implemented any changes interdepartmentally since this study was conducted?
Yeah, so we have actually applied for a second grant, which we were awarded. So we are working on two different things this year that we're trying to implement. One is that additional educational opportunity for earning educational credits to maintain the certified food manager training. And then we actually yesterday and on Wednesday hosted our second translated CFPM course, and we had double the attendance, partly because of COVID, but partly because the word was spread. So that was really great to see.
Okay. And here's an interesting question. What were the obstacles that you experienced for completing a training during COVID-19?
Obviously the in-person aspect. The trainer that hosted the training is very hands-on. She provides a lot of demonstration, and I don't disagree with how she tackles that. And so one of the things we had to push back was not only the training multiple times, but the in-person interviews, and then also gaining people to attend in person. So that is also something our department's looking at, is trying to utilize a virtual platform for some of these applications to not only tackle the communication barrier, but also an oral culture. So.
Okay. And someone wants to know what do you wish you had done differently for your project, if anything?
I don't know. I think trying to gain more information from that core group of establishments we were looking at, and luckily we were able to do that this week. So getting that perspective and that information for more people was a huge help, and everybody has such great ideas that why not ask? So that's probably one thing I wish would change, but we have changed. So.
Got it. All right. Any other questions? I'm not seeing anything pop up for you, Emily. So I'm going to thank you for your presentation. Great job.
Okay.
All right. Well, that brings us to the conclusion of today's, as well as the whole cohort's presentations. So we want to thank you all for attending. And as a reminder, AFPTI will post these presentations and the slides on its website next week, and you can find those. If you want to see the whole research paper, you can go to IFPTI's website, and you'll find all the papers for all the fellows going way back. And you can look at the full project presentations. I'd like to thank all of our fellows, and I hope you enjoyed learning from them, learning from their work. And thank you to AFPTI for hosting this session, these 3 sessions, and to all our sponsors, including AFPTI and Meyer and FMI, Publix, and the AFPTI Foundation. And thanks for this year, and we look forward to Cohort 10 presentations next year, and hopefully those will all be in person. So thank you all for sticking with us, and we'll see you next time. Thanks a lot.